Alright, hey, welcome back. This video is continuing from where we left off in the intro to inflammation video, where we discussed the ways your body recognizes microbes and damaged cells in order to initiate the inflammatory response. So if you haven't watched that video yet, just hit the link at the top of the screen to check that out and then come on back here. But now we are ready to take a closer look at acute inflammation, specifically how blood vessels react to inflammatory stimuli and leukocyte recruitment. Now, we already know that the typical inflammatory reaction moves through a series of sequential steps, and the first is recognizing the offending agent so that an inflammatory reaction can be initiated. But now we are going to actually start looking at the recruitment of leukocytes. And obviously your body has to recruit leukocytes or white blood cells because they're usually just floating around in all the vessels within your body, and it has to bring them to a localized area because you typically have a localized injury. So you want all the cells that are going to help control that reaction in that area. So in order to recruit these leukocytes, your body is going to make changes to the system that they travel on, which is your blood vessels. In order to recruit these leukocytes, the main sort of two categories of changes that your body will make to blood vessels are increases, or at least changes to vascular permeability, and changes to vascular flow and the caliber of your blood vessels. So let's take a look at how your blood vessels go about increasing the vascular permeability of themselves. First thing your vessels have to do around an injured area is make themselves basically more leaky. But how do they go about doing this? So your normal vessels are actually lined by a bunch of cells called endothelial cells. They're not just a solid tube of pipe. And each of these cells has a tiny little space in between each of them where they rest up against each other. Some fluid might normally leak out through these tiny spaces, and that small amount of fluid is usually what your body can clear through its lymphatic system. So there's no net gain of fluid in the extracellular compartment or in the interstitial tissue. When vessels leak fluid into the ECM or into cavities that are outside of your vessels or lymphatics, above what the lymphatics can clear, this gives you edema. So you can think of edema as just extra fluid in the ECM. Now you might think to yourself, why don't your vessels leak excess fluid all the time? Now, if you think about it, there is always an outward push of blood and fluid and just general pressure on your vessel walls from your heart pumping blood through all the vessels. And that pumping force is pushing down the length of your vessels, but again, also outward against the wall. And this outward pushing pressure is called hydrostatic pressure. Now, at the same time, there is also an inward pull of fluid into your vessels, and this is largely due to proteins like albumins, as well as various ions which are located within your vessels. And this inward pull is known as colloid osmotic pressure. This can typically be maintained, or these proteins stay in your vessels because the spaces between those endothelial cells, they're too small for the proteins to actually leak out. So the proteins are just sort of stuck in the vessels, and that is sort of sucking water towards themselves. Normally, there's a net balance of fluid in the vessels with those two pressures more or less balancing out. Again, the hydrostatic pressure is pushing outwards on your vessels through those tiny spaces. That's where fluid's trying to escape. But the colloid osmotic pressure is pulling fluid back into the vessels. And any extra fluid that does leak out, your lymphatics can typically clear. But what then happens if there is increased interendothelial spaces, or if the spaces between those endothelial cells gets bigger? More fluid, and at some point more protein is also going to leak out. And hopefully that should be pretty intuitive, just like a bucket with some holes in the bottom. Small holes will let out a little bit of fluid. The bigger your holes get, the more stuff can leak out of your bucket, and it's the same sort of thing with your blood vessels. Small interendothelial spaces, only fluid is going to be able to escape. Those spaces are still too small for protein to escape, and that is known as transudate. Alternatively, big holes or big interendothelial spaces is going to let fluid as well as proteins out into the extracellular environment. And again, that's because the proteins are larger. Once the spaces get big enough, they will leak out of the vessels. Now, exudate implies that there is increased permeability of the small vessels, and transudate isn't necessarily from increased permeability. Transudate itself can be from a low protein content within the vessel too. So if there's decreased protein synthesis or increased protein loss elsewhere in your body, that can reduce the colloid osmotic pressure. Whereas the only way for proteins to escape into those extracellular spaces are if they leave the vessel somehow. Now, another form of exudate exists, and this is called pus, and is typically a purulent exudate. This is an inflammatory exudate that is rich in leukocytes, mostly neutrophils, the debris of dead cells, and in a lot of cases microbes as well. Now, typically, the increased permeability that we're seeing in inflammation is coming from three things. First of all, the contraction of the endothelial cells that we were just talking about. So there's increased interendothelial spaces, and that is typically the most common mechanism of vascular leakage. The contraction of those cells is stimulated by histamine, bradykinin, leukotrienes, and a couple other chemical mediators, and the response that it creates is known as the immediate transient response, and this occurs right after exposure to the mediator, and it usually lasts a short period of time, 15 to 30 minutes. Now, in some forms of injury, like burns, irradiation, UV radiation, and exposure to some bacterial toxins, vascular leakage might be delayed, so it could be somewhere between 2 to 12 hours before it begins, but it might also last for longer as well. And this delayed, prolonged leakage may be caused by contraction of the endothelial cells, or the next thing that we're going to talk about on this list, which is mild endothelial damage. So if you start damaging those endothelial cells that are lining the vessels, they can become necrotic and actually detach, leaving basically a bigger hole in that solid vessel. Now, direct damage to the endothelium is seen in some injuries, so like burns. Again, certain microbes or microbial toxins can target those cells specifically, as well as neutrophils that we'll talk about later that stick to the endothelium. Sometimes those also injure those cells and kind of amplify this reaction of endothelial injury. And then lastly, we'll see increased permeability from this transcytosis. So this is increased transport of fluid and proteins through the endothelial cell itself. This process might involve intracellular channels that can be stimulated by other certain factors, but the contribution of this process overall to the vascular permeability of acute inflammation isn't as well determined as the first two. Now, the other thing that we discussed in terms of what your body will do to recruit leukocytes is make changes to vascular flow and caliber. I'm going to backtrack a little bit here, and if you could imagine your vessel as a solid tube, one that doesn't leak, even though we just finished talking about how it's not a solid tube, but for now, go with it. So if your vessel's a solid tube, how would you go about slowing down the flow rate to get more cells into a specific area, like the middle of the vessel, for example? And what if you could dilate the middle of the tube? So if you could increase the caliber, it'll take longer for blood to move through that area relative to a non-dilated portion, and the vascular flow in that specific area will slow down. And during leukocyte recruitment, this localized vasodilation is induced by the action of several mediators, specifically histamine on the vascular smooth muscle. And this vasodilation of arterioles is one of the earliest manifestations of inflammation. And the result of the increased blood flow in that middle portion causes a lot of the heat and redness that we'll see at the site of inflammation. And then once this vasodilation begins, it's quickly followed by increased permeability of the microvasculature, so the capillaries, which is also an effect of histamine. And this increased permeability ties into what we were just talking about earlier in relation to edema and exudate. Fluid and proteins can then start leaking out into the extracellular environment. We already have more blood in that area where the vessels become leaky, so we can dump a lot of fluid into that area in a short period of time. Now, this loss of fluid combined with increased vessel diameter leading to slower blood flow, which concentrates all the cells in the small vessels kind of in that middle area. These changes of engorgement of the small vessels and slowly moving red cells gives you a condition called stasis. Now, as stasis develops, leukocytes that are in the blood, mainly neutrophils, will start to accumulate along the vascular endothelium, so the inner wall of the vessels. And as these white blood cells start to accumulate, mediators that are produced at the site of infection or tissue damage are going to activate these endothelial cells to start expressing increased levels of adhesion molecules. Leukocytes can then stick or adhere to the endothelium and start to migrate through the vessel wall into the interstitial tissue towards the site of tissue damage or infection. Before we take a closer look at leukocytes adhering to the endothelium and moving through the vessel wall, we're just going to take a quick look at lymphatic vessels and the responses that lymph nodes will have in response to an infection. So we briefly talked about lymphatics with the hydrostatic and colloid osmotic pressure helping to kind of balance out the amount of fluid loss in regular vessels. They normally drain the small amount of fluid that comes out. But in inflammation, lymph flow is increased because we're putting more fluid into that extracellular space, so your body tries to adapt by sucking up more fluid from there. So it's going to drain more fluid, obviously. But once it starts draining more fluid, you can also get things like cell debris, microbes, leukocytes, which end up in the lymph, and once they end up in the lymph, they'll eventually make their way to a lymph node. If a bunch of microbes and inflammatory cells end up in your lymphatics, they might get secondarily inflamed, so you'll get lymphangitis, or they can affect the draining lymph nodes, which can give you lymphadenitis. And something that your doctor may recognize as a symptom of lymphangitis is the sort of telltale red streaks or almost track marks on your arm near a skin wound, and that's typically a telltale sign that the infection is in your lymphatics. All right, so with that stuff out of the way, we can get to how white blood cells actually make it from the vessels near an inflammatory stimulus to the stimulus itself, which again is typically outside of the blood vessel. Changes in blood flow, i.e. stasis, and vascular permeability increases are quickly followed by a huge influx of leukocytes into the tissue where the inflammatory stimulus is. Now, these leukocytes are responsible for eliminating the offending agent or the inflammatory stimulus, and the most important ones in inflammatory reactions are capable of phagocytosis, and these are going to be your neutrophils and your macrophages. These eat and destroy bacteria, microbes, necrotic tissue, and foreign substances as well. And they also can help by producing growth factor, which helps your body repair itself once that whole reaction has concluded. But unfortunately, when these guys really get going, sometimes they can cause some tissue damage in the surrounding area and prolong inflammation, because the products that these leukocytes are using to destroy microbes and clean things up sometimes just spill over and damage your normal tissue as well. To get leukocytes from vessel lumens into the tissues where inflammatory stimuli are located, there's 3 important steps that need to occur. Within the lumen itself, there's margination, rolling, and adhesion, followed by migration, then migration through the endothelium, and then migration within the extracellular tissue itself. And the sort of control of attachment or attraction of white blood cells to the endothelium and these inflammatory sources are controlled by adhesion molecules and cytokines called chemokines. In a normal blood vessel, your blood flow is laminar. And what that means is the flow is quite smooth, it's not disrupted by anything, and laminar is what you see on this picture on the left. The non-laminar or turbulent flow is basically just a rough flow of fluid within a vessel or a tube or a pipe. And within your blood vessels, the laminar flow or the distribution of cells within a laminar flow is there's a bunch of red cells in the middle, and then a little bit more towards the edge there are the bigger white blood cells. Then as the flow slows, as we get inflammatory stimuli leading to stasis, those white blood cells that are already on the edge of your blood vessels get basically more peripherally distributed and approach the endothelial surface. And this process of coming towards the endothelium or coming towards the edge is called margination. Then as leukocytes get towards this edge, they start to sort of bump into it, sort of attach to it, detach. They've still got some momentum, so they sort of bump along or roll along the endothelium. And at some point, these cells will finally come to rest where they firmly adhere to the vessel wall and they're stuck to enough adhesion molecules that the overall flow of blood isn't going to continue to drag them down the vessel. Now that your leukocytes have adhered themselves to the endothelium, they must make their way between those endothelial cells, and this occurs in a process called transmigration or diapedesis. This typically occurs in post-capillary venules, and chemokines are going to act on these adherent leukocytes and stimulate these cells to make their way through those really narrow interendothelial spaces, which do start to increase in size again within these inflammatory situations, and they're going to head towards a chemical concentration gradient. And step 3 is this chemotaxis, or movement of leukocytes within the extracellular environment towards the site of injury. So again, those chemokines are sort of floating around in the ECM. Once your cell leaves the vessel, it kind of pops its head out, starts sniffing around, and it goes, oh hey, I smell a bunch of chemicals in this direction. I'm going to head that way. And that process of locomoting or moving along a chemical gradient is called chemotaxis. And both endogenous and exogenous substances can be chemoattractions, or things that will attract these leukocytes. Some of the most common exogenous agents are bacterial products, and endogenous attractions can include cytokines, components of the complement system, C5 and C3 specifically, and we'll talk about that more in a later video, as well as arachidonic acid metabolites, and these will be mainly leukotrienes. Now, the nature or type of leukocyte infiltrate is going to vary with the age of the inflammatory response and the type of stimulus. In acute inflammation, which occurs usually within the first 6 to 24 hours, there's going to be a predominance of neutrophils. These are most numerous in the blood versus other type of white blood cells. They respond very rapidly to chemokines, and they also can attach more firmly to adhesion molecules that pop up on the endothelium. Unfortunately, they're relatively short-lived in tissues and will undergo apoptosis within the first 24 to 48 hours. That's okay. After they start to die off, they will get replaced in those 24 to 48 hours by monocytes. And monocytes within your blood, once they leave and go into the extracellular environment, they become macrophages. These have the advantage of being able to survive a lot longer. They might be able to proliferate within your tissues, and they are typically the dominant population in prolonged inflammatory reactions. Now, interestingly, agents that block TNF, or tumor necrosis factor, which is one of the major cytokines in leukocyte recruitment, are among some of the most successful therapeutic agents ever developed for chronic inflammatory disease. And antagonists of leukocyte integrins, which are the adhesion molecules that are going to stick those marginated white blood cells, those are, again, really good at controlling inflammation, and that's beneficial for people who have some kind of chronic inflammatory disease. But they're also a double-edged sword, because you can have inflammation without healing, but you also can't have healing without inflammation. So drugs that control your inflammatory reaction or response too well can also compromise the ability of an individual to respond against microbes. So that was the recruitment of leukocytes. In the next video, we're going to touch on phagocytosis and how offending agents or inflammatory agents get cleared.